Welcome to this module on breast cancer. My name is Dr. Eleanor Latta. I have no conflicts of interest or relationships to disclose with relation to the content of this module. By the end of this module, you should be able to describe the clinical presentation and risk factors for the development of breast cancer, describe and recognize the principles of screening for breast cancer and the methodologies currently available, describe and recognize the histological appearance of breast cancer and contrast with the appearance of normal breast tissue, apply the three modalities of cancer therapy to the treatment of breast cancer, and to recognize the potential psychosocial issues in the treatment of breast cancer in a premenopausal woman, relating to aspects of screening for inherited breast cancer syndrome, prophylactic surgery, or potential loss of fertility. So let's start, first of all, with a little bit about the development of the breast. Breast, or the mammary glands, arise from the skin along embryological milk lines that run from the axilla, the armpits, in a sort of a V shape that comes down towards the groin area. Breasts can actually develop anywhere along the embryological milk lines, and in other mammalian species, of course, multiple nipples and breasts do form along this milk line. In humans, supernumerary or extra nipples may in fact arise along the milk line as inherited conditions. Mammary glands or breasts really are hormonally sensitive, highly modified sweat glands. And they, in fact, as I said, arise from the skin and are in that way analogous to the other glands present within the skin itself. These glands remain quiescent in females until puberty, and of course remain quiescent in males throughout their life. But in females, thelarche, which occurs at puberty, is a sustained period of mammary gland growth. Basically, it's an example of a normal physiological hormonal hyperplasia which occurs. It's in response to estrogen, and it occurs, as I said, in basically young girls that are starting to undergo puberty. A little bit about the anatomy of the breast here. So the breast has several different components which we have to think about. First of all, behind the breast there is the pectoralis major muscle. So the breast is up against the chest wall. You can see the ribs cut through on the side there, and has pectoralis major muscle right behind it. There is a lot of adipose tissue, fat, in the breast. This actually increases as women grow older. Cooper's ligaments are particularly sort of fibrous ligaments, usually tethered to the skin, which help to support the breast. Then you have the lobules, and lobules are the glandular functional component of the breast. So a lobule is a collection of a whole bunch of glands together that form a well-circumscribed structure that's known as a lobule. And as I said, this is the functional unit of the breast. The lobules and the glands within them drain through ducts, which will coalesce then at the nipple areolar complex. Retroglandular adipose tissue, so fat behind the glands or behind the lobules, can also be there. And as I said, since we have the chest wall and the back behind pectoralis major muscle, we have chest wall, ribs, and so on. This is the anatomy then of the breast. What's the histology of the breast? This is normal breast histology now. So a lobule, I said, is the functional unit of the breast, and a lobule is made up of multiple small glandular structures, as you can see in the center of the screen here. Each lobule itself is very well circumscribed. You can see it, you can draw a circle around it. It's very well circumscribed and separated from the surrounding fibrous or adipose tissue. Each lobule, as I said, drains into a duct, and each duct then drains out to the nipple areolar complex. Each gland within the lobule and the ducts are all lined with a double layer of cells. This is important. The inner cells are called ductal cells, and they are surrounded on the outside by another layer of cells called myoepithelial cells. And myoepithelial cells are epithelial cells, but they share some characteristics with smooth muscle. And this makes a certain degree of sense if you think about what the functionality of the breast is. Breast, of course, is meant for one real important purpose, and that's to make milk. And so all of these glands, which you see here in this lobule, when stimulated, will make milk, but they have to be able to also express it and get it out. It has to be able to travel out of the lobule, down the duct, to the nipple. And so having this extra layer of cells around the outside with a little bit of sort of smooth muscle contractility makes it that much easier to express or push the milk out so that the baby can feed. Lobules are separated by fibrous and adipose tissue. I stress again, the purpose of the breast, we have to think about it, really is to provide nutrition. It's there to make milk, it's there to feed babies. However, we also have to recognize that the breast has a certain degree of social significance as well, too. It is quite visible. It has great prominence, of course, in our ideal of beauty or sexual or physical appeal. And therefore, issues around cosmesis, the appearance of the breast, will become very important when dealing in patients suffering from breast cancer, as they may feel diminished or somehow psychologically, made to feel uncomfortable at the idea that breast does not look normal. So let's talk about the breast examination. So let's say that a patient comes in with a breast complaint and a physician is performing a focused breast examination. What do they want to look at? Well, first of all, look at the size and shape of the breasts. Breasts are not usually exactly equal, but they should be relatively about the same size and shape. And if obviously as one looks significantly larger than the other, there may be some underlying pathology. Look at a breast to see the contour. Has it changed? Do you see areas where, for instance, it seems to be pulled, or the skin is tethered or tugging and making it seem out of shape? Has the skin color or texture changed? Are there changes in the nipple? Does the nipple look red, eczematous, sort of like it's inflamed or even ulcerated and bleeding? Does the patient complain of a discharge from the nipple? This could be just sort of colorless liquid. It may look like milk, maybe a bloody discharge. Finally, a breast examination should also include an examination of the axilla, the armpit on the same side as the breast, to feel for any lymph nodes in that area. So what is the primary aim of a breast examination, or the history that you take, when you have a patient who's come in complaining about a breast condition? Rule out cancer. But also remember one very basic fact. Remember that not every breast lump is cancer. And so the primary aim of the history in the breast examination is to try and determine the features of whatever this complaint is or this lump is that a patient is complaining about and decide, is this cancer or is it something else? So what about Canadian breast cancer statistics? First of all, please remember, breast cancer is the most common cancer to be diagnosed in Canadian women, and it is the second most common cause of cancer death in women. Statistics taken from the Cancer Care Ontario, and this was a couple of years ago, so they were looking at 2015, was that the predictions were that 25,000 women in Canada would be diagnosed with cancer of the breast, and 5,000 would die of it. Overall, this translates into a risk of 1 in 9 women can be expected to develop breast cancer over their lifetime. Now, the good news about that is that mortality rates for breast cancer have been declining steadily over the last little while as we get better at diagnosing and treating it. So let's talk about the risk factors for the development of breast cancer. Now, these can be divided into modifiable and non-modifiable risk factors. The non-modifiable risk factors are things that we can't change no matter what we do. We simply have to be aware that they are risk factors. And the most basic one at the top of the list there is age. Breast cancer usually is a disease that is going to occur more often in women as they get older. So a breast lump, for instance, in a patient who is 20 is more likely to be something other than breast cancer, perhaps a fibroadenoma, which is a benign breast tumor, or some other breast lesion. But if you have a breast lump in a woman who's over the age of 50, the odds are that this is most likely going to be breast cancer. If a patient has a positive family history of breast cancer, well, then that's certainly going to increase the risk that they may develop it. Obviously, if you know that a patient carries a particular genetic mutation which is associated with an increased risk for breast cancer, and the most notable one are BRCA1 and BRCA2, this is a non-modifiable risk factor. If a patient has had a previous history of breast cancer, that's a risk factor. If a patient has had previous chest or mantle, across the mantle here, radiation. This is often done in young people, for instance, who suffer from forms of lymphoma like Hodgkin's lymphoma. They get treated with mantle radiation across the chest to cure the lymphoma. That's good, but remember that radiation in and of itself is a risk factor for the development of cancer, and so breast cancer may then develop later on in patients who've been treated this way. Certain reproductive factors are important. Breast cancer is related, of course, to hormonal stimulus, at least to start with. So things like an early menarche, late menopause, so a long reproductive life, and nulliparity, or late age of having your first child. All of them are potential risk factors for breast cancer. Breast density is an interesting one. That has been put out as a non-modifiable risk factor. Certainly, if the more dense the breasts are, you might say, well, if they got more breast tissue there, that's more tissue at risk. But also the density of the breast makes it that much harder, perhaps, to detect breast cancers, and so that may be a factor as well, too. Certain particular ethnic groups may be at higher risk for breast cancer, such as the Ashkenazi Jewish heritage. And finally, if you have a history of some kind of a pre-invasive or dysplastic lesions such as atypical hyperplasia, ductal carcinoma in situ, or lobular carcinoma in situ, LCIS, these are also risk factors. These are the ones we can't change. What are the ones we can help with? Well, modifiable risk factors for the development of breast cancer include diet. And so a healthy, balanced diet is certainly a good thing. There's enough evidence that shows that a diet that's high in fat may be a risk factor for the development of breast cancer. Vitamins. Well, vitamin D has certainly been touted recently as being good for prevention of cancer. Alcohol consumption has been known to have a small but certainly a significant effect in increasing the risk for the development of breast cancer. Obesity certainly does, and that relates to the fact that large amounts of adipose tissue will actually increase estrogen production. And as I said, breast cancer is, to at least some extent, has a hormonal component to it. Sedentary lifestyle or lack of exercise, again, this can contribute to the development of breast cancer. And so we are, again, suggesting that people be more active, they have a good diet, they exercise, and so on. The last is hormone replacement therapy, and this is always a bit of a controversial one because of the benefits of hormone replacement therapy in other areas. Certainly, an estrogen-only hormone replacement therapy would be a risk factor for breast cancer, which is why usually it's given with progesterone. The question of the oral contraceptive pill also comes up. Does this cause a risk for the development of breast cancer? The feeling is it may, but it's a very small one. A little bit now about breast cancer screening and detection. As we've talked about on screening tests, the concept here is that early detection will lead to a better outcome. And so breast screening aims to detect cancer before it's palpable or before it actually comes to the attention, then maybe a patient finds it herself. How can we do this? Well, right now, there is no recommendation that patients should be trying to do a breast examination themselves. What they should, however, do is be aware of their breasts. Try and see if they notice something odd. If they're washing in the shower, do they feel something? Do they notice in the mirror that their breast looks different? Do they notice that there seems to be a discharge from the breast? They should be aware of any changes that occur. There is a clinical breast exam, focused breast exam, which can be done by a physician. But for screening, mammography is the primary screening modality for patients at an average risk. And this usually is recommended that start at age 50 and go up to about age 74, 75, and usually done every 2 years roughly. It can be started earlier in women at age 40 if the woman wants it. However, for various reasons, it's not necessarily recommended there because breasts tend to be more dense in younger women, and it makes it harder for mammography to identify lesions. Magnetic resonance imaging, or MRI scans, is the modality of choice for patients who are considered to be at high risk. For instance, somebody who is known to carry a mutated BRCA gene. In this case, MRI scans would be started at a very early age and would be done yearly. So patients who have known carrier mutations in BRCA1 or BRCA2 will often present at a young age with early onset breast cancer. In young age, I mean maybe in their 20s or early 30s. And they may also have multiple primary breast tumors or involving both breasts. If you have a patient, a young woman who presents with breast cancer, it's worthwhile to recommend genetic counseling and be assessed. And if it in fact found that she has a BRCA1 or BRCA2 mutation, then of course the importance then is to screen other family members. You're going to treat your patient, but let's say she has a sister who also has this mutation. She doesn't have breast cancer, but she has to face the reality that she has a 55 to 80% chance of developing breast cancer and a 20 to 40% chance of developing ovarian or fallopian tube cancer. So this becomes an issue because at that point, the sister doesn't yet have cancer, but may wish to opt for prophylactic bilateral mastectomy and prophylactic bilateral salpingo-oophorectomy. This means prophylactic preventive surgery by removing both breasts and both fallopian tubes and ovaries. This will significantly, of course, reduce your chance of getting cancer due to this BRCA1 or 2 mutation. Not completely, remember, other organs can also be affected, but certainly would prevent the development of the most common ones. However, again, I remind you that there is, as I said, the social significance of the breast. You have a young woman who's maybe 25 years old and is contemplating having both breasts removed and both ovaries and tubes. This becomes very important. First of all, there is a social, cosmetic sense of personal appeal that may be affected. It may, of course, have real problems if she then ever hope to have children. If she have to take out both ovaries and fallopian tubes, you are rendering her at that point sterile as well. How do we diagnose breast cancer? Breast cancer has a triple test. There are the clinical findings, there are the radiology findings, and the pathology findings, and all of these have to be in line. So what are the clinical features that we want to look for in terms of examining someone if we think they might have breast cancer? So you have a patient who was presented in your office complaining about something in her breast. What are the things you want to look for? First of all, is there a palpable lump or mass? Now, I've already stressed, not all lumps in the breast are breast cancer. And in fact, in young women, leaving aside BRCA1 or 2 mutation carriers, most lumps, in fact, are probably going to be benign. They may be cysts, which are just fluid-filled little sort of areas. They may be an area of fibrous tissue. They may be a benign tumor called a fibroadenoma. But in an older woman, the chance that that lump is a breast cancer starts to increase. You want to look for changes in skin color, skin texture. Is it looking red? Is it looking irritated? Changes in the nipple. Like I said, does the nipple look, again, irritated, like it's been scratched a lot? Is it bleeding, and so on? Is there a nipple discharge? A unilateral, one-sided nipple discharge, particularly bloody nipple discharge, is a very actual ominous sign. This is a picture that's been taken. It looks like it's a mastectomy because you can see the nipple kind of in the middle there. And you see the sort of irregularly shaped white mass there in the middle of all the yellow adipose tissue. That is a breast cancer. You can see, again, its irregular borders. It's not smooth. It's not well delineated from the surrounding tissue. And you can see how part of it is reaching out towards the skin, and the skin is actually being pulled back towards it. So this would be something you might see clinically, an area of the skin which looks like it's being retracted or pulled by something underneath it. And that, again, would be a warning sign that there is a cancer underneath. What about mammography? Radiology, I said, findings were important too. Mammography, remember, is the mainstay screening test for women, asymptomatic women, but looking for early signs of breast cancer. What does mammography look for? Well, it looks for asymmetry in the breast. It looks for distortion. It looks for masses, all exactly like we talked about with clinical examination. And it also looks for the presence of calcifications, which will show up in mammography. Again, calcifications may be there in normal breast tissue sometimes, but may also be found in areas either of a pre-invasive lesion or in breast cancer itself. This is what's known as the BI-RADS scale, and this is what radiologists often will use when they're looking at mammography to try and classify or stratify what they're seeing in terms of what else needs to be done for this patient. So they will look at a mammogram and they will give it a BI-RADS score. So for instance, 0, well, needs additional imaging, fine. A BI-RADS 1 or BI-RADS 2 is that it's totally negative, it's clear, it's benign, patient can go off and be just fine. 3, probably a benign finding, maybe suggest having a short interval and then do another follow-up mammogram just to be sure. BI-RADS 4 now, suspicious abnormality, and you should do a biopsy at that point. Or 5, highly suggestive of malignancy, and whatever appropriate action should be taken at that time. Finally, all the way up to BI-RADS 6, which is a known biopsy-proven malignancy. Other imaging modalities, ultrasound can often be done, and usually is done in breast alongside with mammography. And ultrasound is actually very good for looking at cystic lesions. I said cyst is just kind of like a ball of a fluid-filled container at that point. Magnetic resonance imaging, or MRI scanning, as I said, is the modality of choice for women who are at high risk for breast cancer, not average risk, high risk. So this would include, for instance, BRCA carriers. This would also usually be started at an earlier age in these patients and occur more often. Finally, pathology. There are ways to get your pathology tissue that you need to be able to make your diagnosis. 2 main ways are through cytology or through histology. Now, cytology is done by inserting, in this case, a fine needle into the breast mass, and then pulling back or aspirating, trying to suck out a few cells, not a piece of tissue, but literally detached cells, putting them on a slide and looking at them. Now, this is actually not recommended for breast masses for a couple of reasons. First of all, it's often not particularly adequate if there's a lot of fibrous scar tissue, a lot of desmoplastic scar tissue, in effect, in the breast cancer itself. You may not be able to aspirate much out of it. The other thing is, since all you're getting are detached cells, they may look very ugly. Remember what we talked about in terms of a good-looking cell versus a bad-looking cell in cancer. But you can't tell if it's invading or if it's metastasizing, which are the 2 cardinal features that define a malignancy. So an in situ dysplastic lesion in the breast may look exactly the same on cytology as an invasive cancer. Where cytology can be a lot more useful is if you are looking at a lymph node in the axilla, which you are worried about, maybe it's enlarged or feels firm. You can do an aspirate of that, and if you are finding what look like malignant epithelial cells in the lymph node, you can be fairly sure that you have a metastasis there. The ideal way then to get tissue for diagnosing breast cancer is by histology, where you put in a needle into the breast mass and get a core of tissue that comes out. You could do an excisional biopsy of the breast mass, but it's better generally felt that you can get a needle core done and make your diagnosis that way. Breast cancers most commonly arise from the inner ductal cells. Remember, I said there are two cell layers. The inner ductal cells, these are the functional ones. The outer cell layer, these are the myoepithelial cells. Well, if the cancers are arising from the ductal cells and they start to invade and go out into the surrounding tissues, they do so, but they don't bring their myoepithelial cell layer with them. This becomes important from the pathology point of view if you're looking under the microscope and trying to decide if that really is an invasive breast cancer, or do you have something called ductal carcinoma in situ, DCIS. This is a pre-invasive lesion. It's high-grade dysplasia, basically. But it will, because it has not gained yet the ability to invade or metastasize, still have a preserved myoepithelial cell layer around it. I said that DCIS is I said high-grade dysplastic lesion. It can look better, actually, but if it looked better like that, you're not likely to be confusing it with an invasive cancer. So this is a histology slide that's just showing an invasive breast cancer, and you can sort of see from the center of the slide that it looks like the little glands are totally disorganized now compared to the normal histology that we showed earlier, and they just seem to be radiating out from the center in sort of a starburst or stellate pattern. And there is a lot of pink fibrous tissue running in between them. This is the desmoplastic response. This is what makes breast cancers feel firm and hard when you palpate them. Around all these glands, there would be no myoepithelial cell layer. In contrast, this is a focus of ductal carcinoma in situ, and you can see in the center there, it's got certainly more than two cell layers in it, but it has a very smooth border around the outside. It hasn't invaded through its basement membrane. It's still confined within the duct. So this is an in situ lesion. It is dysplastic. It's not yet cancer, but it is a precursor lesion. How do we classify breast cancer? It can be done fairly simply into two categories, what's referred to as no special type. So this is the common garden variety breast cancer, or ductal carcinoma, and this is 70 to 80% of all breast cancers. And then there are the special types, and there's a bunch of them, of which invasive lobular carcinoma is the most common, and that's about 5 to 10% of breast cancers there. The only reason to be making this particular point is that as a general rule, and it is a general rule, if you match a no special type ductal carcinoma grade for grade, stage for stage, with a special type carcinoma, the special types tend to do a little bit better in terms of prognosis. What are the prognostic factors in breast cancer? Stage, big, right there. We use our TNM classification that we talked about, tumor, nodes, metastases. Tumor size is very important. We want to catch breast cancers early because they do better when they're small. We also want to know the status of the axillary lymph nodes. Their histologic subtype, well, I just said matched stage for stage and grade for grade. The no special type cancers will do worse usually than the special types. But even so, that histologic subtype is important. Also, even within the no special type ductal category, certain things are prognostic factors as well. Does the cancer, for instance, express estrogen and progesterone receptors? This becomes important because this will tell us something about can we treat this patient with a hormonal-based therapy. Similarly, does the breast cancer overexpress the HER2/neu protein? Is the HER2/neu gene amplified, producing extra copies of the HER2/neu protein? Overexpression of the HER2/neu protein in this way is actually a negative prognostic factor. It's associated with a worse prognosis, but again, has options for treatment later on. Grade, I've already mentioned. This is, again, rather self-evident. Usually low-grade tumors will behave better than high-grade ones. And lymphovascular invasion. If it's into the lymphatics and vasculature, you have to worry that breast cancer has already metastasized to other areas around the body. A little bit about HER2/neu, since I just mentioned it. HER2/neu is a gene which codes for a protein which is a transmembrane tyrosine kinase receptor. Normally, it's involved in regulatory pathways that involve cell proliferation, cell motility, and survival. It's a normal protein. It's there on all sorts of cells, not just breast cells. and it has a normal function. However, in about 10 to 30% of patients with breast cancer, the HER2/neu gene on chromosome 17 may be amplified, so there's multiple copies of the gene on the one chromosome, which then all get transcribed and translated, so you get overexpression of the HER2/neu protein on the surface of these cells, so on the membrane surface of these breast cancer cells. Significance? Well, as I alluded to earlier, HER2/neu overexpression is associated with a poorer outcome, an increased risk of recurrence, a decreased disease-free survival, and decreased overall survival. It is a negative prognostic factor. So it's not a good thing when it's there. However, it can be the target of a particular form of targeted therapy, and that is trastuzumab, which is an antibody which targets the HER2/neu receptor. Its trade name is Herceptin. As I said, it's a monoclonal antibody. It blocks that HER2/neu receptor and can increase the disease-free and overall survival in patients with HER2/neu positive breast cancers. Still, the benefit of trastuzumab doesn't necessarily outweigh the negative effect of having the HER2/neu overexpression in the first place. So treatment, primary modalities, the same three we've talked about before: surgery, radiation therapy, chemotherapy. Surgery really is the primary modality of choice, at least to start. So most patients with an identified breast cancer would be referred to a surgeon, and then they have a choice. What sort of surgery do they want? They could have a lumpectomy where part of the breast is removed, and this can be done if they can palpate the mass. They'll just do a lumpectomy. They'll take out an area of the breast around the palpable mass. And if it's a very small lesion, which of course is what we're hoping for, and it's not easy to feel, what they would have is called a wire-localized lumpectomy, where a needle or wire is inserted, usually under radiological guidance, and is put so the tip of it is right next to the area of the tumor, and then the surgeon can simply do their lumpectomy around where the wire or needle is located. Alternately, of course, the patient may opt to have a mastectomy, which removes the entire breast. A simple mastectomy will remove the breast, the nipple, and so on. A modified radical mastectomy will also take the lymph nodes at the same time. Is one better than the other? Well, mastectomy will remove all breast tissue. If you have a lumpectomy, of course, you're leaving breast tissue behind, which could still go on to have cancer. At the same time, though, a mastectomy is a very disfiguring type of surgery, even with excellent forms of cosmetic, now reconstructive surgery that can be done. And so one has to think again about the social significance or stigma that may be associated with it. What are the absolute indications for mastectomy? If you are dealing with a patient who has a multicentric tumor, there are multiple quadrants of the breast that have breast cancer or ductal carcinoma in situ. It's not one little localized area, it's most of the breast tissue involved. If the patient's had prior radiation, usually you're going to do a mastectomy at that time because a lumpectomy will usually be followed by radiation. And if you can't follow it with radiation, you have to do a mastectomy. If the patient is pregnant, you may want to do a mastectomy. And finally, the patient may simply choose. They would prefer to have a mastectomy. A relative indication, large tumor in a small breast. If the lumpectomy is basically going to be a mini mastectomy in itself, you may wish to just do the whole thing. The other part of surgery which is important to talk about is the axillary surgery. This is an integral part of breast cancer surgery. It's not just taking the breast cancer out, you must examine the axilla, the armpits. Axillary surgery is performed whenever you're taking out a breast cancer or if you are doing DCIS with a mastectomy. This is important because in the axilla are lymph nodes, which are the first ones usually to drain the area from the breast cancer. Breast lymphatics usually drain into the armpit. And so that's where you're going to look to see early signs of nodal disease. Clinical examination of the axilla, well, if you can feel hard enlarged lymph nodes, that's a pretty bad sign at that point. But a lot of metastases are non-palpable. They're small, they can be seen under a microscope, but they're not going to be felt by palpation. So you have to sample the axillary lymph nodes to get an idea of what the nodal status is. And this is important because nodal status is a very important prognosticator again. It's part of our stage. How can we do it? Well, what they used to do is an axillary dissection where they would just take out a large number of the lymph nodes in the armpit. You might want to think, however, about what potential side effects or consequences that would do. Now, however, we have a different idea of what can be done, and that's called a sentinel node biopsy. The sentinel lymph node is defined as the first lymph node or lymph nodes to which the lymphatic fluid from the breast drains. So you have your tumor, what you're trying to figure out is the lymphatics that run from the tumor towards the armpit. What is the first lymph node that it's going to reach? You figure this out usually by identifying it with a radioactive dye or tracer, which is injected into the breast right at the site of the tumor. You then let some time for it to work its way into the lymphatics and track its way along to the armpit. And then using a combination of looking visually for the dye and also using a Geiger counter, they find which nodes are picking up this radioisotope. They can then remove the sentinel node or nodes. It's fewer than a full axillary dissection, and then they can be assessed by pathology to see if the cancer has spread to them. Now, there are a few assumptions built into the sentinel node biopsy. It's not perfect. And, the assumption is, main one, is that a cancer, if it is going to track to a lymph node, will in fact go to that first node. Is this always the case? Perhaps, perhaps not. Radiation therapy. Radiation therapy plays an important role in the treatment of breast cancer. It's usually used to provide additional local control by radiating breast tissue which has been left behind. So it's always done after a lumpectomy for breast cancer or DCIS. This, as I said, becomes important if they've had previous radiation. This is why mastectomy at that point becomes mandatory, because you can't radiate again. It may sometimes be done after mastectomy if it's a locally advanced breast cancer and you really want to be sure that your site is clean. And may sometimes be done with radiation to the axillary or supraclavicular lymph nodes, again, if you're worried about them. Chemotherapy is the final modality. And this, remember, is a form of systemic therapy. This is not for local control. This is designed to go systemically all through the body and trying to get rid of any micrometastases or floating cancer cells that may have escaped the other two modalities. Chemotherapy may be given actually prior to surgery in the case of a locally advanced breast cancer in order to shrink it and make it more amenable to surgery, but most often is used again following surgery and radiation therapy and given, as I said, just to make sure that there are no systemic involvement or micrometastases or floating cancer cells. 3 primary types of therapy and chemotherapy can be given. One is just chemotherapy in the sense of drugs that target rapidly dividing cells, the same as is treatment in other forms of cancer. Breast cancer, as I said, may express estrogen and progesterone receptors, which makes it amenable then to a hormonally based therapy by giving drugs which act as antagonists to the estrogen receptor, and that's tamoxifen. Since these breast cancers usually, in part, still get some stimulation from estrogen through their receptors, tamoxifen blocking them can be used also to try and prevent them from developing any further. And finally, as I said, if you have a HER2/neu positive tumor, not a good thing, you do have the option now of the targeted therapy using trastuzumab or Herceptin. So your choice of type of chemotherapy will depend on the estrogen receptor, progesterone receptor, HER2/neu status, the tumor grade, and so on. So in summary, remember that breast cancer is the most common type of cancer in women and the second most common cause of cancer death in women. Modifiable risk factors include obesity, exercise, alcohol, diet, and so on. Diagnosis requires the triple test, the clinical findings, the radiological findings, and the pathology findings, and they all have to be in line with each other. Prognosis is dependent on the type, the grade, the stage, lymph node status, and hormonal status. And finally, all 3 cancer therapy modalities are involved in the treatment of breast cancer. So, you should now be able to describe the clinical presentation and risk factors for the development of breast cancer, describe and recognize the principles of screening for breast cancer and the methodologies available, describe and recognize the histological appearance of breast cancer in contrast with the appearance of normal breast tissue, apply the 3 modalities to the treatment of breast cancer, and, as I've stressed at a couple points through this talk, recognize potential psychosocial issues in the treatment of breast cancer, especially in a premenopausal woman. I'd like to make a special thanks to Drs. Ruth Heisey, Frances Wright, Rachel Fleming, and Dr. Christine Elser, all of them who have contributed some information and slides into this particular presentation. Thank you.